Are you curious about how to spot and manage low blood sugar levels in a hospital settings? Well, you are in luck. The third video in the inpatient diabetes management series covers just that. If you missed the first two videos, no need to fret, we've got you covered with the links provided below. So grab some popcorn, coffee, or whatever and get ready to learn all about hypoglycemia in the hospital. Before we start, remember to sign up using the link below for PDF summaries of this and future videos on our channel. Plasma glucose concentration less than 70 mg per deciliter are considered clinically significant in diabetes and require intervention irrespective of symptom severity. Hypoglycemia is a common complication in diabetic patients, mainly in those treated with insulin or insulin-releasing medications, or what we call secretagogues, such as sulfonylurea or meglitinides, and I will come to classification of diabetes medications soon in the course. Non-insulin releasing medications, on the other hand, such as dipeptidyl peptidase 4 or DPP4 inhibitors, metformin, glucagon-like peptide 1 receptor agonists or GLP-1 receptor agonists, TZDs, and sodium glucose cotransporters SGL2 inhibitors are associated with lower risk of hypoglycemia unless used in combination with insulin or insulin-releasing medications. This video will be divided into 4 sections: how to spot and recognize hypoglycemia, how to treat hypoglycemia in acute settings, how to restart diabetic medications, and the final section on how to prevent or minimize the risk of future hypoglycemia in inpatient settings. Let's start with the first section, how to spot and diagnose hypoglycemia in the hospital real-world settings. There are several ways we may discover that our patient is hypoglycemic while in the hospital. The following scenarios accounts for almost 90% of these ways. Low blood sugar detected on a scheduled blood sugar check. Remember, in the hospital, we performed acute checks or blood sugar checks in diabetics ACHS before meals and at bedtime, or at specific intervals if NPO, as we explained in the previous video. Low blood sugar also may be detected on routine labs. Remember, blood glucose is part of the BMP or CMP panel, or the patient is showing symptoms that prompt us to perform an immediate blood sugar check. So what are the symptoms that should trigger an immediate blood sugar check? Hypoglycemia symptoms are divided into probably neurogenic and neuroglycopenic symptoms. Tremors, palpitation, sweating, hunger, and paresthesias are the neurogenic symptoms, while dizziness, weakness, drowsiness, delirium, confusion, and at lower plasma glucose concentration, seizures and coma are what we call the neuroglycopenic symptoms. Elderlies, who represent the majority of our inpatient population, tend to have more of the neuroglycopenic symptoms compared to the neurogenic one. Anyone with these symptoms should get an immediate blood sugar check. So any change in mental status should always trigger an immediate blood sugar check, even in non-diabetics. Whether we called about a patient who is restless, agitated, lethargic, or unresponsive, always think of hypoglycemia first, again, even in non-diabetics. Pay attention to the subtle changes in mental status, odd patient's behavior, odd questions, or if you just feel something not right about your patient, just get an immediate blood sugar check. In the end, a blood sugar check or acute check is a simple, quick, cheap, and non-invasive tests, and no one will question you as to why ordering too many blood sugar checks, believe me. So don't hesitate to do it. Don't forget to order a blood sugar check in code blue and rapid response situations as well. Very important. Let's move to the acute treatment of hypoglycemia, but before we dive into that, I want to go over some terms or some of the treatments we use in hypoglycemia. Rapid acting carbohydrates are carbohydrate foods or beverages that are quickly absorbed and raise the blood glucose level. Example of these fast or rapid acting carbs including glucose tablets, juice, regular pops, candy, and jelly. Fast-acting carbs or carbohydrates typically contain little to no fat or protein. Long-acting carbohydrates are carbohydrates that are absorbed slowly and result in a modest rise in blood glucose levels. Examples to this are bread, pasta, potato, beans, and lentils. In inpatient settings, just give your patient a regular meal or snacks and it should provide them with some of these long-acting carbohydrates. Dextrose solutions, I explained them in my IV fluid course discussed previously on the channel. Let's review them quickly here. D5W or 5% dextrose solution is made by mixing 50 grams of glucose in 1000 cc of free water. D10W or 10% dextrose solution is made by mixing 100 grams of glucose in 1000 cc of free water. D50 or 50% dextrose solution is made by mixing 500 grams of glucose in 1000 cc of free water. In practice, D50 comes in small pre-filled syringes or ampoules by mixing 25 grams of dextrose or glucose in 50 cc of free water, which give you the same osmolarity. 25 divided by 50 is equal to 500 divided by 1000. So it's simple math. You can create your 20 or 30% dextrose solution if you wish to. Most hospitals carry 5, 10 and 50% dextrose solutions. The more concentrated the dextrose solution, the higher the amount of sugar provided and the more hypertonic the solution is. D50, as you can guess, is very hypertonic, but it still can be given safely through a peripheral IV, but be careful of skin infiltration or extravasation, which may lead to tissue damage. Glucagon is available in different forms, including IM, IV, sub-Q, and intranasal. It's mainly reserved for hypoglycemic patients who cannot swallow and lack IV access, so we give it IM, sub-Q, or intranasally. Occasionally, in a hospital setting, a patient may lose IV access and be unable to swallow. In such cases, glucagon can be used to provide treatment. Additionally, if a patient remains hypoglycemic despite other treatments, glucagon may be used as an adjunct therapy. However, it should be noted that glucagon can cause significant nausea, so patients should be given anti-nausea medications beforehand. Let's go back to treatment. As mentioned earlier, plasma glucose concentration less than 70 mg per deciliter are considered clinically significant in diabetes and require intervention irrespective of symptom severity. The treatment of hypoglycemia consists of two things that should be done simultaneously. First, stop or suspend all insulin and non-insulin diabetic medications. This includes switching off the insulin pump if present. And second, correcting hypoglycemia by bringing up blood sugar to above 70 mg per deciliter as soon as possible and then sustaining that above 70. There are two approaches to treating hypoglycemia based on the patient's mental status and ability to swallow. Let's start with patients who are hypoglycemic but still awake and able to safely swallow. If blood sugar less than 40, we give an amp or two of D50 dextrose solutions. If 50% dextrose solution is unavailable, infuse 200 cc of D10 over 15 minutes and simultaneously provide oral rapid-acting carbohydrates like 15 to 20 grams of glucose tablets or 200 ml of orange juice and repeat blood sugar in 10 to 15 minutes. We keep repeating until the blood sugar is above 40. Once it's above 40, the next target is to bring it to above 70, and we can achieve that by providing more oral fast-acting carbohydrates and repeating blood sugar in 15 to 20 minutes. We keep repeating until the blood sugar is above 70. Once blood sugar is above 70, we provide the patient with long-acting carbohydrates. Simply have them eat a regular meal. If it is in the middle of the night and the kitchen is closed, give them snacks or have them drink 200 cc of regular milk. How about patients who are hypoglycemic but unable to swallow? Make sure first to follow the ABC airway breathing circulation protocol while simultaneously actively treating hypoglycemia with an amp or two of 50% dextrose solutions. If 50% dextrose solution again is unavailable, infuse 200 cc of the D10 or D20 solutions over 15 minutes and recheck blood sugar in 15 minutes. Keep repeating until the patient is awake and blood sugar more than 70. If the patient needed to be intubated, keep repeating until the blood sugar is more than 70. Once the blood sugar is more than 70, initiate a continuous infusion with dextrose solution like 5% or 10% until the patient is able to eat or other sources of nutrition are provided like tube feeds or TPN. If the patient's mental status dramatically and quickly improve, we provide them with long-acting carbohydrates. Just provide them with a regular meal or snacks as we discussed. Remember this, the glycemic response to rapid-acting carbohydrates and IV glucose is transient, and that's why we provide long-acting carbohydrates for those who can swallow, and for those who can't, we provide a continuous infusion with dextrose solutions like 5% or 10% until they are able to eat or other sources of nutrition are provided like tube feeds or TPN. Also, one more thing, for patients who are taking alpha glucosidase inhibitors like acarbose, only pure glucose like glucose tablets should be used as fast-acting carbohydrates. Let's move to the third section. When and how do we start or restart diabetic medications? No diabetic medication should be resumed before hypoglycemia is completely resolved. This means that the patient blood sugar has been stable without any treatment, whether the patient is eating or still needed to be in PO. There is no set time for how long to wait before resuming diabetic medications. For example, if hypoglycemia was secondary to sulfonylureas or long-acting insulins, the risk of hypoglycemia might persist for 24 to 36 hours following the last dose, especially in people with renal insufficiency. The decision to resume diabetic medications should be guided by the patient's blood sugar values. Patients with type 1 diabetes have, as you know, no endogenous insulin and should have insulin restarted as soon as possible once hypoglycemia is corrected. Typically, the patient blood sugar should be stable above 140 mg per deciliter for 46 hours without any treatment. Now, on the other hand, in type 2 diabetics, we typically resume their diabetic medications if their blood sugar is stable above 180 for 6 to 12 hours without any treatment provided. So how do we reintroduce or restart the patient diabetic regimen? For non-insulin medications, reintroduce medications that do not affect insulin secretions first, like metformin, DPP-1 inhibitors, GLP-1 agonists, SGL2 inhibitors. Stop or reduce the dose of those insulin-releasing medications like sulfonylureas and meglitinides. Now, for insulin regimen, reintroduce basal insulin first and as soon as you can in type 1 diabetics at a reduced dose along with mild correction sliding scale. Pre-meal insulin should be gradually reintroduced based on the amount needed with the correction sliding scale. Switching NPH insulin to a longer-acting insulin such as insulin detamers, glargine, or degludec should be considered if the patient can afford it. At the end, remember, controlling blood sugar in general is a dynamic process and we may need to go up and down on the treatment based on the patient's response. Use your clinical judgment and use the blood sugar values to guide you. Let's move to the final section, the prevention. After correcting hypoglycemia, the subsequent action should be to avoid its recurrence by determining the underlying cause. Identifying the reason behind the patient's hypoglycemia can guide modifications in medications or diet to prevent its recurrence. Can the patient's hypoglycemia be attributed to a specific cause such as diabetic medications or non-diabetic medications or NPO status or poor oral intake or an underlying conditions like renal failure, liver failure or adrenal insufficiency? Did hypoglycemia follow a specific pattern such as occurring only in the early morning hours, or was it persistent throughout the day? If hypoglycemia is attributed to non-diabetic medications such as pentamidine, quinine, indomethacin, and Bactrim, discontinue those medications immediately. Hypoglycemia attributed to diabetic medications should lead to an adjustment in the patient's diabetic regimen. NPO status or poor oral intake can be prevented by reducing the patient's basal insulin dose by 50% or more, use a mild correction sliding scale, and discontinue all non-insulin diabetic medications. Early morning hypoglycemia can be prevented by providing bedtime snacks and reducing basal insulin by 20 to 30%. Hypoglycemia related to an acute illness can be prevented by reducing the patient basal insulin, typically by 50% or more, use a mild correction sliding scale, and discontinue again all non-insulin diabetic medications. And once they recover, readjust their medication based on their blood sugar values. To avoid making this video too lengthy, I've created a separate video featuring real-life clinical scenarios. Keep an eye out for it on the channel in the next few days. In the end, if you enjoyed this video, be sure to show it some love by giving it a like. And why to keep all this awesomeness to yourself, share it with your colleagues and spread the knowledge. And hey, if you have not subscribed to our channel yet, what are you waiting for? Hit the subscribe button right now. Thanks for tuning in. I'll see you next video.